We are like
A very good evening, everyone. And Maharashtra Ophthalmic Society takes extreme pleasure and privilege in inviting you all to today's webinar, which is Pilocarpine in Presbyopia, a new chapter in Indian ophthalmology. We have a galaxy of ophthalmologists, senior ophthalmologists from Maharashtra joining in today. The session will be chaired by Dr. Anil Kulkarni, sir, Dr. Sharad Patil, sir, and Dr. A. Deshpande, sir. The session will be co-chaired by Dr. Anand Gade, sir, Dr. Shirish Thorat, sir, Dr. Shon Chinchole, sir. We have four eminent speakers, Dr. Jayant Sarvates, Dr. Rahul Deshpande, sir, Dr. Kishore Pahuja, and Dr. Sanjay Rassar. We have a fantastic panel of Dr. Manoj Sasude, Dr. Gopal Arora, Dr. Vardhaman Kankaria, Dr. Praful Chaudhary, Dr. Viral Shah, Dr. Santosh Agarwal, Dr. Rajiv Mundra, and Dr. Sangeeta Wagh. The session will be moderated by Dr. Kunal Shinde, a dynamic young ophthalmologist from Pune. Now, with this, I request the MOS President, Dr. Shirish Thorat, sir, to please say a few words and invite the chairpersons to say a few words before moving on to the session.
Yes. Thank you, Piyush sir, and good evening all. On behalf of MOS, I welcome you all to this interesting webinar on presbyopia management, particularly pilocarpine in presbyopia management. For the years, we were managing presbyopia with the glasses, and its challenges have been an accepted part of aging. Now we have a new options like surgeries and pilocarpine drops, and this can truly make a difference in our patients' daily lives by improving the near vision. We'll be discussing multiple options of presbyopia correction, the science behind the innovations, and practical applications of it. We are lucky to have with us Dr. Anil Kulkarni sir, who is my teacher, Dr. Sharad Patil sir, and Dr. A. Deshpande sir as a chairperson. I thank you all of them for their valuable time. And friends, we are honored to have a panel of distinguished speakers and panelists who are a leading expert in this field. Welcome and thank you all for being here. Thank you, Team Enroll, for coming with such a great ideas. And I'm sure with the lineup of the speakers and topics, it's going to be a great scientific feast and will help us in managing presbyopia protocol in our day-to-day practice. Thank you, and over to you, Piyush bhai. Piyush sir, are you there?
Namaskar and warm evening to all present. Here I am Dr. Kunal Shinde, moderator for this today's section. On behalf of Maharashtra Ophthalmic Society, I welcome you to a session that doesn't just explore a molecule but opens a new dimension in how we think about the presbyopia in Indian landscape. Today's topic is not just merely a pharmacological, but it's a philosophical also. Pilocarpine, once part of glaucoma vocabulary, now finds itself re-emerged as a presbyopic narrative. So, for the today's first talk, I invite Dr. Jain Sarote sir for understanding the unmet needs in the presbyopia. Over to Dr. Jain sir.
Thank you, MOS and entire team. This is a very exciting topic and a new one. Hello, can you see my screen? Okay. Yeah. I think the very fact that we are holding a webinar on presbyopia in itself emphasizes the importance of presbyopia in our life. This is a new topic and new concept. These are emerging. So what is presbyopia? Presbyopia is defined as an inability to accommodate for near, which happens with age. It's a typical disorder found in adults over 40. It occurs due to weakness of ciliary muscles. It gives rise to a blurring of vision for near work, reading work, computer work, mobiles, and gives a lot of inconvenience. And so this requires typically a plus addition of spectacles over and above the distance glasses if the person is wearing any. So this is in nutshell, we have been using glasses for presbyopia, chalishi, what we call it in Marathi. Presbyopia, uh, the occurrence and importance is emphasized because 1.8 billion people have presbyopia globally. That comes to around 45%. The percentage can vary from 30 to 50% in different scenarios, but it is around 30 to 40%. So it is a significant proportion of a working population requires glasses, and it is their vision is hampered because of lack of glasses. So currently this was done, this study was done in 2022, and so overall they said that 26% of the world population is presbyopic. As I told you, it can be different in different scenarios. In India, the multiple studies conducted across India found that in Jhajjar, Haryana, Delhi, Andhra Pradesh, and Telangana, Rourkela, the range was between 30 to 15, 8.9% in some cases. In rural population, it was slightly less because they did not require, ours is a agricultural based country, so they may not need many reading gadgets, or they are not in a habit of reading or writing or for a computer use. But in urban population, you will require these gadgets very essentially, so require glasses in about 58% of the cases. But in rural areas also, because of malnourishment, ours is an underdeveloped country, so malnourishment can lead to early weakening of muscles, and so early occurrence of presbyopia in rural population also in malnourished cases. Why it is important, how presbyopia impacts quality of vision? See, quality of vision is a phrase which is a new mantra and trend in the world of working adults, especially in the middle-aged ones, and especially ladies, because they feel their quality of life has been degraded because of you using glasses. They tend to forget easily. They need different working distances for reading, writing, computer work, threading the needle, and for different ranges from near to intermediate, they will require different glasses. So for these different glasses, these days a progressive glass is required, and progressive glass is used. But this progressive glass sometimes in early stages of presbyopia can lead to an difficulty in adjusting to this presbyopic environment because of different foci which the progressive glass is made of. So this quality of life and how it affects in the daily activities, in threading the needles, using mobile phones, they have got different near distances for which we have to work in. Say for using mobile phones, we require about 35 centimeters. For reading and writing, we will require about 30 centimeters. For threading needles, again, you require about 25 to 30 centimeters. And difficulty using navigation, computer use, you require about 50 to 60 centimeters of intermediate vision. So all these foci to be adjusted in one glass can be sometimes difficult and inconvenient. So if we don't use them, this causes economical implications in cost of glasses, contact lenses, working ability, and career choices. So this is how one can put a blame on presbyopia, if I may say so, that it is not a blame, it is but still people may think in those terms because of their quality of life, which has been till the age of 40 was good. Now it has hampered significantly. And this is a typical study which was done in the US, and they said that the progressive productivity loss is associated with the lack of using glasses, and with the use of glass, the productivity loss significantly reduced. The presbyopic is linked to individual social and economic burdens. It has got a negative impact on people's quality of life as well as nation's economy, as I told you earlier, particularly in low and middle income nations like India. So what is the need for a solution? So this the need for a solution instead of a glass, where you will not need glasses for near work, which is an ideal solution, ideal condition. Work comfortably for near and intermediate distance without glasses. This is what we aim at, and this solution should be very simple in application. So comes in picture the presbyopic use of these pilocarpine drops. So this is how the need for a solution without glasses has arisen, and it has taken its own course. Thank you very much.
Thank you, sir, for your guidance. The next speaker, Dr. Rahul Deshpande, sir, is having some emergency. So I'm Dr. Kunal Shinde, presenting on behalf of Dr. Rahul Deshpande, sir. The topic is evaluating the new Indian pilocarpine drop. So here I'm presenting my presentation. Is it visible? My
Yes, sir, it is
screen.
visible. Yes, sir.
1 second. It is not. It is hanged. Okay. Now it is visible.
Yes, sir, visible.
The topic today for me is the in evolving the landscape of ophthalmology, some innovations feel like whisper, while the others echo like a paradigm shift. Today, I will be talking about the use of pilocarpine, studies on use of pilocarpine for presbyopia in an Indian population. So, the first slide is the clinical study. So this study is a multi-centered, double-blind study and a randomized study. Total 234 subjects were taken for this, and they are placed into the two groups. One is the control group and one is the pilocarpine group. So age group for this study is patients between the 45 to 55. And doses of the drug was once daily, and 100 there is no drop off of the study. This study revealed that there is a conclusion is a pilocarpine 1.2% has the superior efficacy and good tolerability compared to the compared to the placebo in treatment of the presbyopia. Second, to the efficacy results, there is a bar diagram that is showing placebo versus pilocarpine at the day 30 of this study and 3 hours after installation of this drop. This result shows that the around 30% of the pilocarpine users achieving more than 3 lines gain in high contrast near visual acuity compared to a negligible response in a placebo group. The more than 3 lines gain is considered as a benchmark for this study. Statistically, this represents a clinically meaningful effect size aligning with the benchmark from the global GEMINI trials. So this is a frequency map where distance corrected near visual acuity, visual improvement we have checked at the after installing the drop at 15 minutes, 30 minutes, 1 hour, 3 hours, 6 hours, and 8 hours. So this curve demonstrates the time action of profile of pilocarpine 1.25%. The peak efficiency defined by more than 3 line gain occurs at the 3 hours and sustained through the 8 hour. In mesopic condition, this is particularly relevant for the real world tasks like reading in a low light or ambient setting. This improvement is not fleeting, it's a pharmacodynamically stable. Where you can see in a placebo, there is no such gain in the vision. So, comparing to the efficacy results under the photopic conditions, 65% of the subjects reached the near visual acuity of 20/40 or better. This is functionally important. It reflects the ability to perform the routine tasks like reading the SMS, identifying the labels, or using the devices without correction. Intermediate vision gain is also there, captured via the distance corrected intermediate vision acuity were evident by 3 hours, and similarly the depth of focus enhancement is also increased for the distance vision. So coming to the main thing, that is whether it is safe or not. So this is the chart showing the safety results. Safety profile are reassuring. 82% reported no visual side effects. Mild events like the irritation, headache, or transit blurring were self-limited and did not warrant discontinuation. No serious treatment emergent adverse effect were reported. The tolerability of the profile is robust, suggesting a suitability for the broader demographic development. So, coming to the outcomes, it suggests that this is a so this composite table reflects not only the statistical superiority in the near and intermediate vision, but also holistic acceptability of the molecule. Coming to the outcomes, I can say that there is a non-invasive option for presbyopia now. It preserves the distance visual acuity while enhancing the near and intermediate acuity, and complements surgical and optical correction that way. So, as a closing, as a clinician, our vision must extend beyond the retina to the foresight, insight, and oversight. So pilocarpine 1.2% offer not just the lines of acuity but lines of possibility also. In my practice experience, those who are readers and in the age between the 45 to 50, those who have 3 to 4 hours of reading, especially in the evening, this drop gives them a good result. Thank you, Anton, for giving this opportunity, and thank you, Rahul Deshpande, sir, for giving this opportunity. Any questions?
One question I have.
Yes.
Whether it is useful for computer people, because computer PC users especially, they have intermediate distance,
Yes.
and many people use mobile also.
Yes.
So how that can be explained with the pilocarpine, and in also different professionals like sportsmen or other people, can they use this type of medicine for presbyopia?
In my experience, I have used it for very limited patients, and those who are readers, they get more benefit rather than the computer visions or the sports person. But study trial shows that there is an increase in the intermediate activity, which is a computer, and there is an increase in there is an increase in distance visual acuity also. So theoretically, going to the clinical trials, yeah, it is helping all. But in reality or practicality, I have very limited use of this, and these are helpful for those who have a reading work or reading or writing work.
Okay, thank you.
I will invite Dr. Kishore Pahuja sir for the next talk. That topic, his topic is clinical trial insights, Gemini 1 and 2. Over to Dr. Kishore Pahuja sir.
Thank you, Dr. Kunal, and thank you, Intart, for being me here. Is my presentation visible?
Yes, sir.
Okay, and am I audible also? Thank you. I think Dr. Kunal has kept things easy for me. Basically, this I'm just telling you before Entart came and then started an Indian study. So these are the studies which were available for pilocarpine 1.25% eye drops. Now, these are three clinical studies that I'm going to talk today. One is in a GEMINI 1, which is the objective of this study was to evaluate the efficacy and safety of pilocarpine hydrochloride 1.25% in individuals with presbyopia and adults. The design was vehicle control, double mass, randomized, multi-centered phase 3 clinical study, and the number of sites, which was 36 sites in United States. And number of participants was 323, which is 1:1, placebo versus pilocarpine. And age group was 40 to 55 years, and duration of treatment was 30 days. And dosage was once daily. Now, the primary endpoint, which was kept as a proportion of participants getting 3 or more lines in mesopic, that means 10 to 11 lux at a target. So why we are talking about in a mesopic? Because when there is an photopic people, in that there is an anyway, because of the brightness, your near vision improves. So this was done for an mesopic pupil, and within a high contrast binocular distance corrected near visual acuity on day 30 and over 3. So that means 30 after 30 days when you put in a drop, and then 3 hours after that the vision was checked, and result was 30.7% participants gained more than 3 lines improvement. Now the benchmark which was kept as was in a 3 lines, but in the patients that we are seeing, that I see about 2 lines improvement in the patients. Now, efficacy results that were seen, the vision improvements were measured at different time points: 15 minutes, 30 minutes, 1 hour, 3 hours, 6 hour, 8 hour, and 10 hour. The reason for that was because we wanted to
Sir,
see that once you put
excuse
in a
me,
drop.
we are not seeing your slides one by one. Only first slide is seen.
Oh,
yeah, now we can see, sir. Can you enlarge it, magnify it?
I'll do that. Yeah.
Go for slideshow so that it will be enlarged.
Yeah, I mean, I did that, but why my first slide was seen? I'll see that whether there's any other presentation open.
Now we are
Can you click?
able to
Can you
see
click on the
6.
slides? Can you click on the slideshow at the top and start? Then you
Yeah,
only slideshow
Slides are visible but not readable. So you can go to the top and there is a slideshow
yeah, sir.
column. You can just click that. So you will be able to do that. Otherwise, there is a cup. That cup also, if you can click, that will also do. That is, cup is in the lower part.
Is that seen now?
Sir, can you just stop share for a minute?
Same, it is the same.
Sir, can you just stop share? Dr. Pahuja?
Stop sharing.
Just stop share. Dr. Pahuja, stop it. Can you just click on the share button once?
Yeah.
And left hand side there is you have an option called entire screen. Just select that entire screen and then go share.
Entire screen, yes.
Okay,
Go
I'll
back.
go in entire screen. But I'll go to a window and then see whether I can share with this now. See now?
The same thing.
Sir,
No,
now you will have to make
now?
it slideshow mode.
Yeah,
Slideshow में
I'll
डालिएगा.
make it
Yeah, do
slideshow, but now
that.
it's seen
Click
now.
there. Click there. The same button you have to click.
Now it's seen.
No. You are restricted we the layout of the screen. So you have to go back and say full screen.
Dr. Pauja, on the top menu, right? वहाँ पे slideshow लिखा रहेगा. On the top, when you see the bars, top एकदम top है,
Yeah,
जहाँ
there
red
is
color का
a
bar है. Slideshow, there is a slideshow written. Right hand
yeah.
side, sir, right hand side. Slideshow
Yeah,
लिखा
but
रहेगा.
now it's seen.
No, sir, top पे sir slideshow लिखा रहेगा. Can you just see
Yeah,
that
I mean,
menu?
I can see my slide.
And you stop sharing now.
Again, you start sharing and then go with the full screen.
Abhi, when you click on share button, left hand side पे there is an option called entire screen. Just select that entire screen. Click on share button once. Left hand side top पे entire screen का
Here,
option होगा.
the green button arrow.
Yeah, but I have to share first my presentation.
Yes. No,
Yeah.
don't select your presentation. That's what I'm trying to tell you. Just select the entire screen.
Okay.
Entire screen. Don't select the presentation. Select the entire screen and then blue button.
Okay.
Now click on the PPT.
Yeah.
And now make it full screen the way you were doing earlier. नीचे
now
वाला
it's seen.
जो button.
नीचे
You
वाला
will have to
कर सकते
slideshow
हैं
में डाल दीजिए.
Now it's seen.
Perfect, sir.
It's better, yeah, definitely.
Okay.
Okay, perfect.
Okay, so now I'll start from here. Okay, so this is a GEMINI 1 clinical study which was done for the objective was to evaluate the efficacy and safety of pilocarpine hydrochloride 1.25% in individuals with presbyopia in adults. And the comparison was with the vehicle controlled double masked randomized multi-centered phase 3 clinical study, and total number of sites which was 36 sites in US, and number of participants is 323, which is in the ratio of 1:1. So placebo and pilocarpine drops. And age group which was selected from 40 to 55 years, and duration of treatment was 30 days, and dosage was once daily. Now, the efficacy results, which was the primary endpoint which was seen, was on the gaining 3 or more lines in a mesopic, which was 10 to 11 lux at target. High contrast binocular distant corrected near visual acuity on day 30 and hours 3. So that means when you put on a drop, after 3 hours, the vision was checked. Results as 30.7% participants gained more than 3 lines improvements, and the efficacy results was that vision improvement were measured at different time points: 15 minutes, 30 minutes, 1 hour, 3 hours, 6 hour, 8 hour, and 10 hour, and at different conditions of mesopic and photopic, and in different distances, which was distant corrected near visual acuity and then distant corrected intermediate visual acuity. Now, the significant vision improvement has been observed at every point at compared to a vehicle. So the common adverse events which was seen was a headache, visual improvement, hyperemia, eye irritation, and all adverse events were mild and no treatment was needed for that, and no participant discontinued due to an adverse events. Now, then the GEMINI 2 study came, so then they tried to evaluate the efficacy. So this was treating presbyopia, and the design control was vehicle control double mask randomized multi-centered phase 3. But in this group was LASIK PRK group and non-LASIK PRK group. And the age group was same 40 to 55 years, and duration of treatment was again 30 days, and dosage was once daily. Now the conclusion was pilot treatment effectively and similarly improved distant corrected near visual acuity in presbyopes with or without an history of laser vision correction. So this was in a GEMINI 2 study, and the efficacy again was same as in the LASIK PRK versus vehicle, and LASIK PRK versus Pilo non-LASIK PRK group. So the results were measured that mesopic distant corrected near visual acuity, and the photopic distant corrected near vision acuity, and photopic distant corrected intermediate visual acuity. Now the efficacy was mesopic, distant corrected near visual acuity on day 30, and in that 35% of LASIK PRK participants gained 3 or more lines. So that means this can be used in the also in the patients who have undergone a refractive surgery. Now, photopic distant corrected near visual acuity on day 30, and that 40.5% LASIK PRK participant gained 3 or more line improvement in photopic and distant corrected near visual acuity as compared to vehicle on 30-day and 3 hours. So this is in a bar where you can see that the vision improved on 0, 0.25, 0.5, and then 1 hour, 3 hours, and then 6 hours, 8 hours, and 10 hours. And the photopic distant corrected near visual intermediate visual acuity on day 30. In that, there was also a significant improvement in photopic intermediate vision as compared to vehicle on day 30 at every point of time. So, every time when this was seen. Now, this was an outcome of that GEMINI 1 and 2 studies. We said pilocarpine treatment effectively improves near and intermediate vision without compromising distance vision in individuals with presbyopia, regardless of whether they have undergone previous LASIK PRK surgery or not. So this may allow continued independence from spectacles. Now then, there was another study which is called as a VIRGO study, where they studied the dose was in a twice daily dosage, and the percentage was same 1.25%, but the dosage was twice daily, 6 hours apart for 14 days for presbyopia. The design and settings was phase 3 randomized 1:1 controlled double masked multi-center. Number of subjects were 230 and age group was 45 to 55 in this, as compared to GEMINI 1 which was 40 to 55 group. And the duration of study here was 14 days, where in GEMINI was about 30 days. And here the dose was twice daily. Now, in this, near vision improvements were statistically greater with Pilo twice daily than with vehicle without compromising distance visual acuity. And the safety profile of pilocarpine twice daily was consistent and systemic accumulation was minimal, supporting twice daily administration. Now, the endpoint was mesopic distant corrected near vision acuity at 1 hour, 3 hours, 6 hours, 7 hours, and 9 hours. And in results, 36.8% of participants gained 3 or more lines in mesopic distant corrected near visual acuity without losing more than 1 line for a corrected distance visual acuity at day 14 and hour 9. So 6 hours after the second dose. So that means we are looking at the mesopic pupil in that the distance visual acuity was slightly reduced. Now the key secondary endpoints was mesopic distant corrected near visual acuity gaining 3 lines, photopic distant corrected near visual acuity gaining 3 lines, and then mesopic distant corrected near visual acuity gaining 2 lines, and the mesopic distant corrected near visual acuity was 20/40 or better vision. Now, the patient-reported outcomes was greatly benefited with pilocarpine in terms of their routine near acuities regarding ability and etc. The change from baseline in mesopic, if you see that the performance score of this, can you see my marker? So this was in a vehicle, and this was in a pilocarpine. The green was in a vehicle, and the purple is in the pilocarpine. And the change from baseline in mesopic was almost improvement. If you see an improvement and deterioration, so almost 89%, 90% they had an improvement from a baseline. Now, change in pupil size, the reduction in pupil size observed over time in the pilocarpine twice daily group.
Sorry to disturb, sir. 3 more minutes.
Yeah. So, suggesting a mechanism of action primarily based on pupil constriction. And so, if there's any questions, I'm here. Thank you very much.
Any questions from panelists?
Yeah, just can I ask? I'm Dr. Gopal Arora here.
Sure, sir.
Just because the studies which has shown that the 6 hours difference between the second dose gives a better result. So does it mean that this is going to be the new norm of a BT dose of pilocarpine?
No, sir, this is especially the people who want work for a longer hours of the day. Then for them it is recommended that you put it twice daily. But if you're just working only, you want only in the morning hours and you don't have any work in the evenings, then probably it's a once daily dosage.
Okay.
But the only disadvantage when you continue in the evening hours or in late night, then the distant corrected visual acuity because is reduced because of people construction. Because routinely, because when there's a dark here, people become mesopic or an scotopic. In that, the distant corrected visual acuity was slightly reduced.
Yeah, I was wondering because especially when you're using in the post afternoon and if you're driving in the evening, would that be a problem?
Yes.
Okay.
Thank you, sir, for this enlightening talk. I would like to invite Dr. Sanjay Rasal, sir, for the next topic. Topic name is current surgical options for presbyopia management. Over to you, Dr. Sanjay Rasal, sir.
अनम्यूट करा लागेल.
Yes, you are
Sir,
unmuted.
mute आहे.
Now you are audible, sir.
Am I audible?
Yes, sir. And your PowerPoint is visible.
I will start again. Is that okay?
Yes,
Sir,
sir.
just put off your video off.
Respected chairpersons, co-chairpersons, panelists, Chairman Scientific Committee Dr. Piyush, Moderator Dr. Kunal, and
Dr.
the whole
Sir,
team
can
of
you just
Control.
stop your video?
Hello.
Yeah, there's an can you stop your video?
Hello.
Yeah, now.
Can you hear me now?
Yeah, now it's better, sir.
So, respected chairperson, co-chairperson, panelist, moderator, chairman, scientific committee, Dr. Piyush, and whole team of Entoad, thank you for giving this opportunity to me. I will be talking on current options for the treatment of presbyopia. Now, previous speakers have told about the pharmacological treatment for the presbyopia. I will define presbyopia as a physiological and inevitable condition wherein amplitude of accommodation gradually goes down, leading to progressive blurring of the near vision, which becomes clinically evident and significant during fifth decade of life. The purpose of this presentation is to provide an update about current procedures available for presbyopia correction, their advantages and disadvantages. And these surgical options are divided in corneal procedures, lens procedures, scleral procedures. We'll see one by one if our time permits. We'll go through the historical also. Majority these procedures are corneal procedures and then lenticular procedures and scleral procedures. Coming to the corneal procedures, they are divided into non-ablative and ablative procedures. Laser procedures are monovision by LASIK or PRK, presby-LASIK, intracor, inlays, corneal inlays, and non-laser procedures is conductive keratoplasty. In lenticular procedure, we have monovision with the monofocal IOL, refractive lens exchange by multifocal, trifocal, EDOF, varifocal, or progressive accommodative IOLs. Presbyopic multifocal phakic IOL is another option nowadays. And in scleral procedures, we have anterior ciliary sclerotomy, scleral expansion band surgeries. So coming to the monovision, which is most commonly used for the treatment of presbyopia, that we can achieve with the LASIK, PRK, or monofocal IOL, while correcting ametropia, whether it is a myopia, hypermetropia, or astigmatism, along with presbyopia, we can correct these with the monovision. The dominant eye is corrected for the distant, while the non-dominant eye is for the near vision. But the problem with this is we are creating an isometropy of say 2.5 diopter in two eyes, and that gives interocular blur. And this blur reduces the quality of binocular vision and stereopsis. These are the limitations of monovision. Again, another limitation is regression. In younger patients, there is aggressive healing, so the effect tend to regress. Also, myopes can read easily by taking off their glasses. They are very happy while reading after taking off the glasses, but they are literally frustrated when they feel like their near vision quality is gone down after refractive surgery or say monovision treatments. Inherent problems associated with the LASIK, PRK, like regression, FRAP-related complication, DLK, ectasia, and dry eyes are there. So monovision has come in the form of mini monovision. In mini monovision, the induced myopia is typically targeted between 0.75 to 1.5 diopter in non-dominant eye than 2.5 diopter in traditional monovision. So there will be no interocular blur or less effect on the binocular vision and depth perception as compared to the traditional monovision. So coming to the monovision with the monofocal IOL. Now we all are using, we know we are using intraocular lenses for decades. And initially we used to use a spherical IOL, then came the era of a aspheric IOL. Now we are talking about the negative aspheric IOL that negates the positive aberration of the cornea. However, in studies done by the Rocha and Eckenders, they show the small positive spherical aberration helps increase the depth of focus, allowing greater range of vision. So the best approach to use IOLs with the zero aberration optics or the IOLs with the neutral spherical aberration like one with the Bausch and Lomb, Acryos. So all in all, when we treat these patients with the monofocal IOL, we better use spherical or positive spherical IOLs for monovision. Coming to the lens based, another most commonly used procedure is lens based procedure. Here, basically the presbyopia is an issue of a zonule, ciliary body, and lens. So it is always better to target the lens than the targeting cornea, the innocent cornea. Unfortunately, we see a lot of procedures done on the cornea than on the lens. But nowadays, we all know the refractive lenses has come in a big way for the treatment of ametropia like myopia, hypermetropia, astigmatism, along with the presbyopia. And the IOL portfolio like multifocal IOLs, trifocal IOLs, even EDOF, varifocal, progressive IOL, and accommodative IOLs have been tried to treat the presbyopia successfully. And we are getting really good results with these IOLs. However, multifocal IOLs have their inherent problems associated with the ring design. That ring design of the multifocal eye, like reduced contrast sensitivity, glare, halos, mesopic vision issues like rings around the light, are not tolerated by some patients and may require IOL exchange. These are limitations of the multifocal IOL and trifocal IOL. So we came in the era of EDOF IOLs, and EDOF IOL offer good range of intermediate and distant vision. However, not all patients with the EDOF IOLs are happy with the near vision. So we came in the era of varifocal and progressive IOLs, and these IOLs give really good vision for the distant, intermediate, and near. They are really very happy, and the speed of reading, if you see with these IOLs, they do wonders. So this looks really promising IOL in future for me. Coming to the accommodative IOLs, this has become little historical IOL, but as a part of presentation, I have included few slides for this accommodative IOL. Accommodative IOL uses focus shift principle. With the contraction of ciliary muscle, attempt of contraction of the ciliary muscle, this IOL moves forwards, increasing the dioptric power of the eye. There are two types of accommodative IOLs, position changing and shape changing IOLs. Position changing IOL is a Cresta lens with the 1 millimeter movement is equivalent to the 2 diopters of power change, and they say it gives good, reasonably good vision for the near vision. But another IOL is shape changing accommodative IOL, wherein with the attempt of accommodation, the fluid that is there in the haptics comes in the optic, and that optic swells up by say 2 diopter, and gives near vision. And with the deaccommodated state, the capsular bag squeezes the fluid in the optic, and that lens get deflated, giving a good distant vision. I don't know where these lenses are available, but that is in the literature, so I included in my presentation. But there are limitations of accommodative IOL. The axial shift and true accommodative effect is very small, variable, and even negligible. Distant vision is not significantly better than the monofocal vision, and there is no statistical significant correlation is found between axial shift and distant corrected visual acuity. At this time, further studies are necessary for widespread acceptance of this accommodative IOL. That's why many of us are stopped using accommodative IOLs. Now coming to the presbyopic implantable phakic IOL. This has come up in the big way, but the high cost involved in implanting these IOLs is a major hindrance using these IOLs. Though the procedure is reversible, the basic design is multifocal ring design, and it has its own set of problems with the ring design. Again, the issues of the vault giving rise to secondary glaucoma and secondary cataract. The options we have are ICL, IPCL, and sulcoplex lenses from the Renner. Coming to the presbyopia, again we are coming back to the cornea, because cornea is an innocent structure. It is not at fault for the presbyopia, but unfortunately it is handled by many, and a lot of trials are done on the cornea, and some people have made it a multifocal in order to get a good distant, near, and intermediate vision. And it is first attempted by the Morera using PRK. There are two types of presbyopia: central and peripheral presbyopia. In the central presbyopia, we create a hyper positive area in the center for near vision, whereas the periphery or mid periphery is treated for the distant vision. Only advantage is minimal central tissue ablation is required to create a central hyper positive in myope, hyperope, or emmetrope patient. While in periphery, we use central cornea for distance. We keep central cornea for the distant vision, while the mid periphery we treat for the negative asphericity, and depth of focus is increased for the near vision. Then there are limitations of the peripheral presbyopia, like relatively large amount of frenal tissue needs to be removed with the excimer laser to create that negative asphericity in the mid periphery. At the same time, we need to take care of that central tissue that should not get ablated. So it requires highly efficient excimer laser beam profile. So these are limitations of the peripheral presbyopia. And all in all, presbyopia has a lot of limitations: loss of best corrected spectacle vision by 2 lines, decreased vision quality because of its multifocal nature, reduced contrast sensitivity halos, and I would say more scientific evidence is needed to support its widespread use. Coming to the corneal intrastromal femtolaser. Again, this is another method where the cornea is handled and it's like I would say insulted in a bad way, where Luis Ritz in Bogota in Colombia did first case of intracor in October 2007. He used a Technolos femtosecond laser to apply a completely customized pattern of intrastromal femtodisruptive laser pulses in the corneal stroma of a non-dominant eye in a series of 5 concentric cylindrical rings from posterior to the anterior stroma to induce localized biomechanical change that reshapes the cornea in a multifocal hyperprolate form. And the net effect is central stiffening of the anterior corneal surface that gives good near vision. But at what cost? We are damaging the mid stroma to get that central stiffening. So there are few advantages. He said there is no pain, inflammation, haze, as a procedure is purely intrastromal. The speed of recovery is really fast due to the absence of surface wound like LASIK or PRK. The stability of refractive error is there because they say they preserve the anterior corneal fibers, but at the same time there are a lot of limitations of the intraocular procedure. There is a high dependability on proper centration and alignment. Without centration and alignment, it is difficult to give that concentric 5 rings at a different layers of the cornea or stroma. There is a dissatisfaction with the hyperprolate abrasion pattern. The visual disturbances are due to cavitation and gas bubbles. The progression and regression over time because of the biomechanical corneal forces, diffractive effect from the paracentral laser pulse delivery. And of course, all these only give a clue that further studies and larger number of eyes should be treated and longer follow-up is needed to say that the intracorp is a really good procedure for the presbyopia. Coming to the corneal inlays. Corneal inlays are also called as a keratophakia, where we implant small bicompatible inert device in the corneal stroma, either superficial or deep stroma of a non-dominant eye to improve the near vision. There are 3 types of corneal inlays. One is a refractive inlay, corneal reshaping, and small aperture inlay. Coming to the refractive corneal inlays, they work by changing the refractive index of the cornea and are designed with the different dioptric zones similar to the multifocal IOLs or contact lenses. Here the central zone is neutral for distant vision, which is surrounded by one circular zone with the additional power for near vision that is shown in the diagram below, schematic diagram. The central rays are going straight, that is for the distant vision, while the blue color rays are the mid peripheral rays. They have additional power that brings the near object in the focus. Presby FlexiView microlens is a refractive type of inlay. It is a transparent hydrogel implant made up of a hydroxyethyl methacrylate or methyl methacrylate. Its diameter is 3 mm and is 15 to 20 micron thick from center to its periphery. It has a central neutral zone surrounded by multiple rings of progressively increasing power from 1.5 diopter to 3.5 diopter, creating a multifocal effect, just like a multifocal contact lens or multifocal IOL. It is placed in the mid stroma around 200 to 300 microns depth, which is optimal for the nutritional flow across these lenses. That is also important because otherwise the corneal tissue will melt when will go in a necrosed tissue. So they have some minute holes to facilitate or so the nutrients or oxygen across these lenses, and the ICO lens is commercially available outside the US. Coming to the small aperture corneal inlays, here you can see there is a small aperture and the surrounding zone is opaque. This works on the principle of pinhole. That pinhole increases the depth of focus and gives good near vision. The best example of the pinhole effect is camera corneal inlay. It is also known as an ACI 7000. It's opaque ring-shaped inlay made up of PVDF and carbon. Its diameter is 3.8 mm with 5 micron thick and 1.6 mm central aperture. It has 8,400 laser etched holes to facilitate diffusion of aqueous and nutrient across this lens. And as it is kept in the mid stroma, there are chances of corneal erosions or say explantation of this inlays.
Sorry to disturb you, sir. 2 more
yes.
minutes time.
Yeah, 2 minutes.
Yes, yes.
Yeah, I will wind up. I will wind up. They are designed to, the third one is a corneal reshaping inlays. These are designed to increase the central corneal curvature for the near vision. The paracentral portion is thinner. The example is a raindrop inlay. It started in 2016, but unfortunately it is discontinued because of the corneal haze in 2018. The advantage of corneal inlays is good functional vision at near distance, safe as compared to risk involved in RLE because these are intraocular procedures, phakic IOL, LASIK. They have their own problems. So they compare this with the invasive procedures. However, they have their own problems. Reversibility, they say, is possible. Combination with the other refractive procedure is possible. With the LASIK flap, we can implant these inlays under the LASIK flap. So corneal inlays have their own problems like halos, glare, disturbance at the night vision, loss of contrast sensitivity, difficulty in reading in dim light because of the pinhole effect, effect of the pupil size. It doesn't work in a large pupils or say myotic pupils. Corneal haze is there, as I said, raindrop inlay, dry eye, central corneal flattening, and hyperopic shift that particularly happens in the camera inlays, less decentration, keratolysis, vascularization, opacification, and in worse cases, epithelial ingrowth. Conductive keratoplasty, I won't go in details because it's of historical importance. Coming to the scleral procedure, anterior ciliary sclerotomy, there are radial 4 incisions are given. This theory of accommodation, Chachar's theory, say with the expansion of the sclera, increasing the space between the equator of the lens and ciliary body, which results in more tension on the equatorial zonules. However, and moreover, with the increased effort of the accommodation or contraction of the ciliary muscle, this gives more tension on the zonules, giving rise to accommodative results and increasing the near vision. The another procedure, scleral expansion segment surgery, where PMA bands are placed in the partial thickness scleral tunnel incision overlying the ciliary body, which gives a scleral expansion effect and stretches the zonules and giving near vision. However, all these procedures are very really invasive and has a lot of effects like loss of effect due to scleral healing, scleral weakening, and ciliary ischemia. So all these are of historical importance. I wonder how they are tried for the correction of presbyopia. So in conclusion, after extensive review of all the modalities, techniques and their results and literature, it is very clear that there is no unique and ideal solution for the correction of presbyopia. In fact, in search of restoration of true accommodation remains a challenge. And another major point is neuroadaptive response of in the presbyopia have not been adequately studied. So I feel strongly, barring few multifocal IOLs or say progressive IOL, there is no ideal and unique solution for presbyopia. So I really congratulate and thank the team of Entod who is coming with the really innovative idea of treating this most common disorder or disability, I would say. And the population and statistics that already highlighted by Dr. Sarvate sir, there is a potential market for this drug and it will do wonders in near future. I really convey my best wishes for the team Entod for this new product. At the same time, for any surgical procedure, I would say ophthalmologist should decide which surgical management is best for each patient. Most important recommendation is to help patient to set a realistic expectation and together with the subject evaluation, predict the effectiveness of surgery. Thank you.
Good evening, dear colleagues and mentors and visionaries. As we draw curtain on today's enlightening webinar, I am filled with quite awe because what we witnessed wasn't just a discussion about a molecule, it was a convergence of mind, a mosaic of insight, and reaffirmation of why we chose this field. Now, to restore clarity, not only in ocular but also in conceptual. So, for a vote of thanks, I would like to invite Dr. Sean Chinchole sir. Over to Dr. Chinchole sir.
Also disagree about British positions and as prestige governments.
Hello, good evening all.
Good evening, sir. You are audible.
Yes. First of all, thank you, Intod, for giving me this opportunity to say vote of thanks. As a MOS barrier on the off of Dr. Shirish Thorat sir, President, Dr. Viral Shah, Secretary sir, Piyush Bansal, Chairman Scientific. I would like to thank all the presenters and requested Pauja sir, Rasar sir for these updates. And thank you very much for the attendees who have participated. Special thanks to Anand Deshpande sir, our from Aurangabad, Jayant Satarkar sir, Sanjay Rasar sir, Dr. Vardhaman, Dr. Anand Gade sir from Nagpur, our MOS President, Dr. Gopal Arora sir from Nagpur. Then thank you, Dr. Kunal, for seeing this program. Dr. Praful Chaudhary sir, thank you. And I will thank all the presenters and participants. Thank you, Intod, especially Dr. Thank you, Raman Marke from Intod, who did this program nicely. Hope to see you with nice eye drops. Few questions are always there in mind because in the morning I received this Presbyopia eye drop and I install in my OT assistant. He's a 55-year-old. Somehow I feel he's little bit happy, but after 2 hours he again started wearing that spec. Then I asked him that what happened. I think we also need that. Even Pauja sir told in the afternoon also you have to put the drop. So I think some more precise things has to done for this drop. So thank you very much, and thank you Intod and each and every team. Thank you very much.
Continuing this last experience, I would like to have views of our panelists. First of all, I would like to thank you panelists for your questions and reflection, give the depth and dimensions to every slide and every statement. I would like to invite panelists for their experience with and Dr. Manoj Saravde sir.
Sir, please unmute yourself.
So I had a few questions. Could I ask? I'm Dr. Sangeeta Wagh from Pune.
Yes, ma'am.
So would the Pilocar have different effects in Indian eyes because of the dark iris? Is it possible that the effect is less in duration as well as the depth of focus as compared to, the West has launched the same drug that we used as anti-glaucoma. So will there be a difference in the dark iris as against the light iris? Are there any studies on that? And would that have indications to the timing? Like, Dr. Shone just said that his OT assistant in 2 hours found the loss of the effect. So is it possible that the action can be short-lived because of the dark iris?
Can I answer that question?
Yes, sir.
Yeah, see the studies which are done in US, in that if you see there were an improvement of 3 lines, and somewhere it was more than 3 lines. But in Indian study which was done, there was a 2 line improvement, and max was a 3 line improvement. Because we are just part of that study also. So in Indian eyes, if you see that the improvement is less than the Western eyes, maybe because of the anatomical changes that we have, dark iris and this.
The other question I had to Mr. Raman of Entod is that why is it 1.25%? We know that earlier the Pilocar was available as 1%, 2%, and 4%. So is there any specific reason other than maybe the patenting or marketing? You may not be allowed to sell the 1% as a presbyopia correction because maybe it's WTO or whatever it is, but is there any specific reason as to why 1.25% was chosen?
Shall I answer as a panelist if
Yes,
nobody
yes,
is
sir.
answering?
Yes, sir.
The thing is that 1% is just sufficient, but it cannot sustain the reaction till a longer time. There was 1.2, 2%, 4%. They are extreme, and that can cause not only the ciliary muscle contraction, but will also cause the spasm also. Now I will give a little information about this study, what I feel myself. This study is being done only on the positive research, that is called the positive research. Negative research has not been done, or if done, it is not exposed in this webinar, because negative research is that what are the complications that are happening, what is the survey of the market when it is you are using in the market. And what I found and at what I feel, what is happening whenever you are putting a pilocarpine 1.25%, okay, it's okay, but it will cause, because it is a cholinergic agonist, so it will cause the contraction of the ciliary muscle. And ciliary muscles, when contracting continuously, may go in spasm. When they go in spasm, they squeeze the ciliary vessels, and there is a huge congestion in the ciliary vessel. So many people may start ciliary congestion permanently, temporarily, or they may cause that, and that is a which they may not like, because that may give the another reasoning for that ciliary muscle congestion. So this part, that is a negative research should be done, and survey must be done, how much people are getting the reaction of the ciliary congestion. To my knowledge, lot many people are having that problem, and that survey should be done as a social survey. And when your market is flooded with this medicine, and so many people are there, the survey is must. So what you said in Indian, definitely, because there is a more melanin, and so the more melanin acts sphincters. They don't allow the sphincters to contract, and so there is a less effectiveness. So 1.25 is chosen as a balancing place, not more, not less. And so it is 1.25, and that becomes unique of the endode also, that we provide 1.25.
Thank you, sir, for the explanation. Are there any contraindications described where we should not be using other than allergy or hypersensitivity?
Naturally, the malignancy of the ciliary body, so iris or anything anywhere. So that is the biggest contraindication.
Mainly high myopic patient, ma'am.
Yeah, and any UVI.
Because there are chances of vitreous traction or any macular changes or retinal detachment as
True.
well in
True.
such
Correct.
cases.
So we also need long-term studies, and I would also worry about people using this for 20 years and then coming for cataract surgery, where you'll have rigid pupils.
Yeah, definitely.
So long-term, I think we need
Long
to.
term and just immediate survey should be there. Negative survey. That is called negative research. That
I
should be
have
done.
one question, sir. Can this be applied as a monovision? Like, because of the long-term problems, is it possible in there would be only select candidates where, say maybe for half the day you put in one eye and half the day you put in other eye, or one day you put in one eye and one day the other, like simulating a monovision. So that would reduce the risks of long-term complications as well. And, it might give you that monovision that you otherwise simulate. It's just a
That
thought. I
is
don't know if it has been tried in.
that is also a best idea.
Should I comment on this?
Yeah.
Yeah. So see, basically the studies which was done for in a short period of time to see the efficacy of the pilocarpine drops, right? 1.25 was selected because the study GEMINI 1 and GEMINI 2 and the VIRGO study which were done within a 1.25%, right? Now the question here is that if you're looking into a long-term use of this, and when the medicine was stopped, and at that time it was seen that there was no remnant effect of an pilocar in the evening, right? So the pupil dilatation, and it worked exactly in the same. So the second question was often the high myopes using an retinal detachment. I think high myope people probably will not use it because they are happy, just remove the glasses, then you can read that. For them, it's not. It's usually it's for an emmetrope presbyopic patients. They do very well with this.
Again, the thing is that as it is a cholinergic and agonistic, it stimulates the glands in the body, nerves in the body, and so they may have some different effects upon different glands. If the nerves are stimulated, the supplied nerve, which the gland is having the supply, on the gland itself is also stimulated. So that effects are not being, that is to be studied nicely, and that also should be seen, because it is to be used for a longer period.
Uh, exactly, sir. Probably the reason of giving a side effects which was seen by using this medicine was a mild headache, mild these things, whatever the side effects were seen with that. But the severity of that side effects was not that the patient had to stop the medicines, right? What you're saying is there has to be a systemic side effects, depends upon that how much is an absorption of the drops into a systemic circulation. So that is, if you consider a 1.25%, it's a very meager amount which is going to be uh, in a systemic circulation and causing a side effects of that.
One of the absolute contraindications would be a patient with iritis or iridocyclitis.
That is true.
Right.
So the
Yeah.
patient will have
Irritable eyes, irritable
So,
eyes.
see, I mean, I think probably this is not a drug which has to be over the counter, and I think probably the societies like Maharashtra Ophthalmic Society or AIOS or this, they should have some consensus over I mean, when see now this study has been done and now this drug is available in the market, we'll understand, and probably the study has to be continued where we understand what are the effects which are coming for this. So probably the societies like AIC or they should have some consensus. It should not be over the counter drug, and like I mean how the low dose atropine is started. So the same way this has to be in some consensus where you use it and in this condition with this contraindications. So probably I think it's a new drug in the market and we'll have to look into this, and I think probably all the people will give I mean each one gives a feedback, probably that will make a little bigger study.
What I think, sir, it should be used as a cosmetic medicine. I think whenever you go out or you are working in a very means you are going in the conferences or somewhere like that, then that time you can use it. So not often, means not
Exactly.
on daily basis.
Exactly. Purpose is that when you want, when I mean, you go for suppose if I say I mean, you go for a party and you don't want to wear any glasses and you want to see something, put in a drop, go for the party, come back and then enjoy. Right? It's not I mean, I don't think it's in a routine everyday use that you want to get rid of any glasses and
It,
use this medicine.
it will obviate many problems and your complications, likely complications and side effects also.
Right. Yeah.
It should also come under some kind of a scheduled drug, because otherwise it's going to be
Exactly.
free available
Exactly.
over the
Yeah.
counter, and
So that's what I'm saying. It has to be probably the company has to work for that, and all the societies has to come within a consensus that this drug should not be over the counter. It has to be only within a prescription, and these are the indications and then the contraindications and the relative contraindications.
So
and
it
no
should
full
be in the
page,
list of the scheduled drug.
no full page advertisement in newspapers, which will
No, we are happy that this
it
time
was launched and we were all horrified when we saw like you open newspaper and Purna Pan Barun advertisement.
no,
So
but
that was a shocker, and
we're happy that this time Entod has come out with a proper launch of this medicine, not in a public domain, but in a doctor's domain, means in the conference itself. So it will not be used means like water, means it will be used very precisely. And many congratulations to Entod also. First time they have come out with this novel medicine in the Indian market. We are very thankful and also congratulate him.
Thank you, all panelists. Your narratives bridge the gap between the evidence and empathy, reminding us that the innovation doesn't come in isolation. It comes when science meets the needs. So tonight, as the pilocarpine steps into a new role, we too are invited to see with the fresh eyes. We eyes that not only measure the vision in 6 and 6, but also in the meaning. So let us carry this insight back to our clinics, to our communities, and to our classrooms. Thank you all for this wonderful webinar.
thank you. Good night.
Thank you, and good night, everyone.
Good night, everyone.
phone.